Hi everyone. This side Dr. Abhinav Chabra from Medanta, Gurgaon. Dr. Chandra will be joining us in another 5 minutes. So our patient is a 59-year-old gentleman with a past history of coronary artery disease, had a PTCA done in 2013 to LAD and D1 bifurcation. At that time, he presented with angina and he underwent this procedure 2013 a long back, and he was doing well till like 7 days back when he had an episode of unstable angina, and he was diagnosed as inferior posterior wall MI in the hospital, where he was thrombolized and was stabilized for next 24 hours, and then he was presented to us with the this type of angiography. So angiography was done on day before yesterday, which revealed patent stents in LAD and diagonal with a very good flow in both the stents and minimal restenosis. Next shoot. So this is the long LAD stent with the diagonal stent at the bifurcation, which is very well flowing. And the LAD distally has approximate 90% distal lesion. And next. So this is the aleocranial view, which is also showing a good flow in the stents with a minimal restenosis. Circ is having a small, although it is a very small vessel and having a 80% stenosis in the mid part. And the main lesion was in RCA. Next please. So this was the RCA lesion. In between, at the midpoint, there is ruptured plaque with a thrombus inside, and the distal PD is also having some thrombus. PLV is also having mid approximate 70 to 80% disease. So our plan was to again anticoagulate for next 1 to 2 days, and then we'll plan for stenting to this RCA.
नहीं इसको एक स्टेंड
So
उल्टा में लगेगा
today we have
और एक
taken
आध
the
स्टेंड ऊपर लगेगा
check
दो
shoot to
तीन
the
स्टेंड लगेगा
RCA. So this
तीन
was the
पर
RCA. So this is the RCA today. So distal PD has a good flow now without any thrombus, and PLV has small disease, which is already mentioned in the previous angio, and there is a ruptured plaque in the mid RCA. So we have wired the RCA in the until the PLV distally. So next plan will be discussed by Dr. Chandra sir.
Okay, so we will, as you already mentioned, that this right coronary artery is the culprit today, and he has been a thrombolized patient, acute coronary syndrome. So we have given in heparin and dual antiplatelets already loaded. So we will do a IVUS now. Can we do an IVUS and see what is the situation? So you can see very well that this is a typical picture of ulcerated plaque, and the distal vessel is also having some disease in the PLV, which we will see whether we need to do a drug-eluting balloon or because it's so distal that it might be better to do a DEB. Okay, so this is a volcano. The advantage of using a volcano in this is that, you know, it is very quick and don't have to do any major preparations. Although, you know, people do discuss about the hurt, you know, the depth, you know, basically it's since it is a 20 megahertz versus a, so you can see that we are not able to cross the this IVUS catheter at this point, which means that this lesion, which was not appearing that much on the angio, but on this angiogram today, but probably it is significant, and we see that there is some calcium. So we'll pull back, and yes, there is calcium here. Can you do just a quick check? Yeah, where we are. Yeah. So this is very clear that this is a significant lesion out there. And okay, so pull back, the artery is looking good, and we see some disease here. And okay, nothing to complain. And here we can now, we are reaching towards the lesion. Okay, so here it is. So you can see that calcium is there, and also that the lesion is showing some degree of, disease there. And this is the tightest part, you see, and there is some ulcerative lesion here, mixed heterogeneous plaques out there. But interestingly, the distal lesion is quite significant. So we have to dilate it with a 2 millimeter balloon. Give me a 2 millimeter balloon. Yeah. So the mid portion, which was the ulcerated one, which was looking very, the significant lesion, it is significant, but on IVUS, we see that the flow is happening, and the MLA, how much is the minimal area? It's 2.8. 2.8. And the vessel size is about 3 millimeters. So looking like a 3 millimeter artery. This is a 2 millimeter balloon?
Yes, sir.
Yeah. 212. So this is a 212, which will be used to dilate this. And can you check? Yeah. Yes.
Next was IVUS,
Yeah.
where it was.
Connect. Check. Yeah, this is the area. Okay, go up. 2, 4, 6, 8, 9, 10, 12. Go a little bit eleo. Eleo, please. Eleocranial. Or more. That's it. That's it. Deflate. So we can pull back a little bit. Check, please. Check. Yeah. Okay. Go up. 2, 4, 6, 8, 10, 12. Okay. So we have gone up to 12 atmospheres, and the lesion seems to be done. Go up more. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12, 14. Okay, deflate. So here we are with the
Fluid then, sir.
basically, no, the guiding is a little bit inside. Yeah, it's okay. Okay. So you can see that the guiding actually went a little bit deeper inside, and that's why the pressure was wedging.
Cutting
Now we can, no, we have to do the
IVUS again.
IVUS again. Aram, don't. Okay. So now there's again the same IVUS on the sync vision. So this is the new sync vision from Volcano, which we are using today. And see how the catheter moves now. So it moves by quite nicely, you see. Yeah, it has crossed the lesion. And we go a little bit more distal. So this is the distal most part, okay? Can you check, please? Okay, so the vessel looks like a 2 millimeter vessel. And we might have to do a cutting balloon with it too, because there is a fibrocalcifix area. So give me a cutting with two, please. So we'll take a Wolverine 2 millimeter. So what do you have? 210, 215. I think 215 should be better. 215. Okay.
We have to do cutting in LED also if you want to take them.
Yeah, so we'll use the same balloon for the LED because that is also a 2 millimeter distal part. So we'll see. That is next. Since this PLV is a very big artery, we'll respect this length, and that's why we are treating this. Okay. Okay. So it moved very nicely without any issues. And we are going to do this. Check, please. Okay, go up, please. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So this is 10 atmospheres with this Wolverine, and we'll keep it for about 10 seconds. Pressure, please. Show the pressure always. Okay, deflate. And I will check a little bit. Check.
Air is there in that guide.
Check. Check करिए. Okay, so we'll pull it a little bit back and then go up more. Go up. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12. So we are doing a further dilatation of the proximal segment of the RCA PLV, and you can see that it is a 2 into going up to 12 atmospheres. And so this is our dominant strategy when we are treating small vessels, good as much as plaque modification. Certainly we cannot do a rota here. Would you do a rota here? No, never, because it's so distal. What would you do? Nothing else. This is the best strategy in this situation. Deflate, please. Okay. And I'll also check this now. The length of this lesion, certainly not big. Okay, just store it. We don't need to dilate with this balloon because the lumen is already okay. And there we are. Okay. So you see that this lesion is well treated now, the distal lesion with a 2 millimeter. And we will take a DEB. So give me a DEB, please. 2.25 should be fine. Give me a 2.25. Give some nitro. Nitro, please. Nitro. And so now which drug-eluting balloon are we going to take? So typically, now since the sirolimus-eluting balloons are available, and we have now, show me the last one, the last shot. So should we take a 20 or a 25? That's the question. Take a shot, please. Shot. This looks very nice. I think 25 will be better. Give me a 25. Okay, because there is some little plaque there, we can just touch that as well. Or maybe a 30. What about a 30? 2.25, 30. 30 will be better. Give me a 30. 2.25, 30, please. And now you can see that this PLV is growing bigger and bigger and bigger. So, yeah. 2.25. What you have?
35.
35.
25 will be
25 will be better. Then give me 25. 2.25, 25. Yeah. Show me the first shot, please. I want to just identify what is our landing zone for this. Yeah. Okay. Next, please. Next. Yeah. So here it was just after that branch, there was an issue, right? So we'll go right from there. Okay. So this is a 25 millimeter, and this is a 2.25, 25, and this is the solution which comes from Medalliance, and now it is a J&J stent, J&J balloon. So there's a drug-eluting balloon which has, the release kinetics are slightly different because the drug is, in some kind of a globules, what they have made. And the balloon is wrapped in a proper way. Check, please. Okay, I can go a little bit further. Okay. Okay, check, please. Yeah, fine. Go up. 1, 2, 3, 4. Yeah, 5. So the nominal is 6, and with the 2.25, and at 5 atmospheres it is 2.23, and the size looks quite good. The vessel ID was about 2.2 to 2.25, so we are fine. I don't think we need to go any further in terms of pressure. And how long will we keep? Generally, we keep for about 2 minutes
Previous shoot.
if the patient is tolerating. Okay.
Stent size.
Stent size, we will see. Go to the first shot, please. First one. Yes. So here we can see that it is about, I think, 28 or something like that, or maybe a little longer. We will see.
Yeah, 20, 29, 30.
Okay. So we are
In
presently how many? 1 minute. So this is a sirolimus eluting 2.25, 25. It's already 1 minute. Okay. Fine. And then we will slowly deflate it at the end of 1, maybe 2 minutes. Just wait. Since he's tolerating so well, why not? That's very good. Go to LEO view. LEO, please. Plain LEO. Tube down. Yeah. Okay. Fine. So this is quite well dilated. And so it's 1 minute 42 seconds. And generally the recommendation is to go for anything above 30 seconds. But if he's tolerating, 2 minutes is the usual time which we give. Okay. Deflate, please. So it is 2 minutes now. And yeah. So I'm taking this balloon out, and with this thing, I will make a check. So let me just, no, don't shoot. Now take a shoot, please. Okay. So you can see that the distal lesion is very well done. There is no residual, and there is no dissection. Everything looks good. And this is a 25 millimeter balloon up there. To measure the size of the stent we have to take, and you can see that we can easily take maybe a 30. It's better to take a little longer one.
Yeah, 30 to 34.
38. 38. Give me a 38, please. 338 or a 3.25 38. How much was the size of the vessel on IVUS? Well, okay. So the landing zone, the distal landing zone diameter is how much? Distal landing zone diameter, let's check. More. Yeah, somewhere here. Go down. Yeah, give me a 338. So there are plaques all over, but certainly we'll match the luminal diameter and the distal segment, and then proximally we can go ahead little higher with a 3.5 if required. Yeah. So we are taking a 3.338. 338. Okay. So this is 338. Okay. And this is Zines Alpine. Zines Alpine 338. Okay. Check, please. In this area, it looks okay. I think we are fine. Okay. Check, please. Yeah, it looks very good, actually. We are fine. Go up, please. 1, 2, 3, 4. 5, 6, 7, 8, 9, 10, 12. So we are going up to 12 atmospheres. Stay there for 30 seconds. So this is, generally if you are implanting definitely with a longer stent also, remain at about the implanting pressures for 20 to 30 seconds. Okay, deflate please. Okay. Now I'll go again at the same place. Go up. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12. Okay, so the size looks good to me. Fully expanded. Okay, deflate. Okay, so that's okay. So now we can check and see how it looks. Okay, check please. Looks fine. Store it. Store please. And show please. Okay, so I think we have to dilate a little more. So whether to take a 3 millimeter balloon or a 3.5, I will IVUS it again, because sometimes the vessels are in spasm. So in those situations, we have to give some nitro in between. And have we given some nitro? Give some nitro. Give some nitro. So there is no major issue, and slow flow is not there. Although it was ulcerated plaque acute coronary syndrome, we were expecting that could be that there will be some slow flow, but the flow is absolutely TIMI3. And now I'm going to check it. Okay, live. Check. Live. On. Yeah, so just beyond, this is beyond the 3.5 stented segment. I'm pulling back. Yeah, I think we need to expand it with a 3.5, because I can see that the vessel has grown now. And but of course, the lumen is looking good still, and there is the proximal edge, and fine. Okay, stop. So how much is the size here? 3.5. Okay. Like going up to 3.3. Okay, so give me a 3.5 balloon. So lower edge, we will go at a slightly lower pressure, and then proximal segment, please. 3.5, 10. Okay. Yeah. Proximal to it, just proximal. More proximal, more proximal. Landing zone. Yeah. That's right. Yeah, here. So this is also about 3.5. Yeah. So I think we'll have to better do it with a 3.5. Although there is no dissection, there is nothing major here, so we are fine. But we'll optimize it more by this thing. Okay. Okay, so I can see on the live this thing. Okay, go up please. 1, 2, 3, 4. So there is the live stent boost. Again, this is a system which comes with this volcano system. 4. Go up to how much? 4. 4, 5, 6, 7, 8, 9, 10. Deflate. So it looks like we have covered the stent edge. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12. I think the stent is now very well expanded. Deflate, please. And the beauty is that we don't have to do any cine runs. It just comes on the fluoro. So this is radiation protection. Go up 2, 4, 6, 8, 10, 12, 14. Okay, deflate. So okay, 14, 14, 16, deflate. So we are going gradually inch by inch. Okay, yeah, 16. You can see that this place we need some better dilatation. 16, 18. Yeah, the dilatation looks quite okay. 20. Okay, deflate. Okay. So we are just at the edge. I'll go up here. Go up 2, 4, 6, 8, 9, 10, 12, 14. Okay, 16. Deflate. So the proximal edge is done. I'll go a little bit inside. Okay, 16. 16, please. 18. Okay. Okay, fine. So we are done. Deflate, please. Okay. Okay. So check now. This is fine. The distal vessel also looks very good. There is no major dissection anywhere, and there is no flow related issues. And I think, we are almost done. So we can check in the other view also. RAO, please. RAO, plain RAO. Yeah. Take a shot, please. This looks nice. And there is a TIMI3 flow all over. And I think the branches are also well preserved. There is no issue with the branches. Both the RV branches are okay. Fine. Okay.
Yes.
Yeah. Should we do a final IVUS? We can. I mean, quickly. It doesn't take too much time. So we should not try to cut short things. Do completely, because this is a very big artery and we need to respect it completely. Show, please. Okay. Yeah. Okay. So pull back now. Yeah, now it is a very well expanded stent. You can see full apposition, good MSAs, and proximally also looks excellent. Okay. So no dissections pre and post, and both at the distal and the proximal edges. So we are done. Okay. Yes. Is there any question on the? Please take this. Yeah. So I'll take this RCA catheter out, and we'll go to the left system now. The left system we had stented several years back, and all the stents are doing fine. But he has some distal disease in the LAD segment, which I'm going to show you. So give me a left guiding catheter. Yeah. And this was a bifurcation stent we did. So which year was angioplasty done for you?
2013.
2013.
13.
So this was 10 years back. Okay.
We have discussed this in the history.
Okay. 10 years back.
Yeah.
So and the stents are bifurcation stenting was
Yes,
done.
bifurcation stent.
Yeah. So which technique? Is there any mention of that? Was it a DK crash or? I think most likely it was a DK crash. Yeah. Okay. Okay.
Where it is.
Yeah. So come to the RAO caudal position. Okay. So I'm going to take a shot for the left artery. Yeah. So the stent is flowing nicely, but just distal to the stent, there is a disease which you can see. And epicranial, please. Just from the proximal stent and into this RO, please. Little bit RO. Yeah, that's better. Okay. So just distal to that, and it is a reasonable length of segment. So no, there could be some discussion whether to leave it or just do it, since it is just after the stent. Although the stent was done 10 years back, it's fully endothelialized. Still, I will say that if we are able to do something, it will improve the outcome for this patient. So I'm taking a BMW again, the same wire which has been used earlier. Give me this thing. Yeah.
2 का balloon ready.
Check. Okay, come. Epicranial, please. Okay, so we are in the diagonal. Okay. And we want to go to the LAD. Okay. The wire is going everywhere. Can somebody check it? Check distally.
Distal wire.
Okay, fine. Right. So we are taking the same 2 millimeter balloon first. 2 millimeter?
Yes. 212.
212. And this is a mini track from Abbott. And it's a mini track or an NC track?
NC track.
So it's an NC track. And hopefully it will cross. I mean, we will eventually do it with a same Wolverine 2 millimeters, but with such tight lesions, especially if the Wolverine has been used in the other lesion, it won't cross. Okay, check please. Okay. Go up, please. Go up. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Deflate. Okay. Go up. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Deflate. चलो इसको निकाल लो. ठीक है. Check please. I think this looks nice. Go up. 1, 2, 3, 4, 5, 6, 7, 8. Deflate. So this is a 15?
10, 12.
12. Okay, give me a
Cutting ready.
This is Wolverine. So I'm taking a Wolverine now, which is same 2 into 15.
Yes.
Okay, very good. And after this, we will do the IVUS to see whether we are treated the lesion well, and then it will be followed by, if everything is okay, a drug-eluting balloon. Because so distal, putting another stent may not be a great idea, unless until we are pushed to do that.
Negative.
Okay, check please. I might check. Okay. Okay, go up. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. That's nice. 12. So this is a 12 atmospheres Wolverine 2 into 15. Go up a little bit more. 13. Okay, that's good. So in small vessels, and especially if we are planning a DEB, better to atherectomize as much as possible. Deflate. Okay. Okay, go up. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12. 12. 14. Okay. Keep it. Okay. Deflate. Okay. Check, please. This looks very nice, actually. So I think I have nothing more to do. Maybe one more inflation.
Distally.
Not distally, in the proximal part, just in the tightest portion, and then that'll be it. Okay. Go up. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12, 14. So we go to reasonably, high pressures, and then so that we do as much atherectomy as possible. Stop, please. Stop. Deflate.
35.
Okay. Check now. We can do some more dilatation distally. Okay. Go up. Go up. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12. Okay. So
Size 15, 30.
what?
The depth size.
Size is 15. So we'll take a 30. Deflate. Yeah.
2.5.
So give me a 2.25 or 2.5. So we can take a 2.25, 30. Let me check with IVUS. Give me some. So we should do some imaging now at this stage. See how it looks. Okay, so we are going to do an IVUS to this vessel and see how it looks. Okay. Okay. So it went easily. So this is the normal segment here, 2 millimeters. And also with this, we can measure it. So it is like what?
25.
25 might also do, or 30, whatever. Okay. So this is, yeah, much better. The lumen is very good. And here we can do some more inflation, maybe, you see. Although the lumen is looking like a 2 millimeter at that side. And okay, that sounds good. So we can go with the same balloon a little bit higher in the proximal segment. So it becomes 2.25. The same Wolverine. Hold it. Since it is a small vessel like 2 millimeters, we will go with either a 2 millimeter DEB 225. 225 or 230, whatever. Both can work. Or a 2.2525.
Negative.
Okay. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12, 14. 16. At 16, how much is the size now of the Wolverine?
Wolverine goes up to 2.5 ही हो जाता है.
Deflate about 2.4 or something like that. Okay.
225.
So what are the choices we have? Go up 2, 4, 6, 8, 10, 12, 14, 16. Okay.
In
Fine.
2.25 we have 35 and 2 in
Deflate.
25.
225 will be fine. Deflate. 225. Okay. 225. No. 225. So now we are taking a 2 into 25, and this is a solution Again, solution SLR from Mid-Alliance. And this we did the first study, which was the de novo study. And the first in man study was done here. And the outcomes were very positive. In our experience, we have done nearly about 300 or something like that, or maybe more balloons for de novo lesions. Yeah, so here you can see this comes in quite easily, and is going to connect it. Okay, check please. Yeah, this is perfect. Okay, go up. 1, 2, 3, 4, 5, 6, 7, 8. Okay, so what's the size at 8? This 2 millimeter is at 8, it is 2.03, and we can go up to, and it doesn't expand too much. So it's
12.
At 12, it is 2.09. So 8, 9, 10, that'll be fine. 12, perfect. So we are good to stay it like this. Make it come to RO caudal position. So we'll come to RO caudal position. Okay. 2 minutes. So we'll give a 2 minutes inflation. As you can see here, the balloon is well expanded. Looks good. At 12 atmospheres. Just distal to the stent which was implanted 12 or 10 years back. So his age is 59 now. First angioplasty was done at the age of 49. Yeah. Two minutes inflation. Are there any questions?
No questions.
Okay. 1 minute 14 seconds, and the pressure is okay. ECG is okay. He's feeling all right. So we will continue for 2 minutes. Okay. So 1 minute 40 seconds, another 20 seconds, and we will stop. Okay. Deflate. So this is 2 minutes of inflation with this solution SLR 2 into 25. Let's see how it looks. Okay. This looks absolutely perfect. There is no dissection, there is no residual, and the vessel looks very, very nice. Okay. So we are done. And I'm just taking this balloon out. Okay. Okay, so we take the wire out as well and take a final shot. Perfect. So this vessel is looking very nice now, very healthy, and there is no residual, there is no dissection with this drug-eluting balloon to the, this 2.0 to 2.25 vessel, distal segment. I think this is the way to go in these kind of vessels. Okay.
Yes.
Yeah. So you want to say something?
Yes. So again, this small vessels which are being treated and are showing a very good result. Although Dr. Chandra has done more than 500 cases in such vessels, and you can see the results in 2013 as well. We can Dr. Chandra himself can appreciate like how wonderfully it is flowing.
So I'm quite happy that
Another
everything is
20
okay.
years patient can do very well now.
Yeah. Dr. Singhal?
Supposedly, I have a question, sir.
Yeah.
If supposedly after doing depth in this small kind of victims,
Mhm.
we find that there is a small dissection or something. So what should be the further strategy? Should we
Yeah.
leave it? Should
I mean, yeah, that's a good question. Basically, if there is a dissection, generally we see what kind of dissection it is. If it is up to grade 2 dissection, we leave it. If it is a non-flow limiting dissection, we leave it, because these dissections have a tendency to heal, so that, you know, natural healing process also happens. In case the dissection is, you know, flow limiting, it is like a spiral, and it is like the flow is getting impeded, then you stent it. That's the way to go. Okay.
We have to check in 2 or 3 more
Yeah.
views.
So we checked in 2 views. Everything is okay. We can stop. So with this, I think we can stop here. Thank you very much. And we will share with you again at 4 o'clock other cases. Okay. All the best. Okay. You're feeling okay? Very good. Very good. बहुत बढ़िया. Very good. Thank you. Thank you.